And depending on where we finish at, we don't have class tomorrow because we'll be done with this. So if we finish this, we're good to go. I will be here tomorrow. I told y'all already about leave for the exam on Monday. I'm going to give you the breakdown, but also make sure that you know that everything is going to have to be off of your desk, like everything. We have to pass out the papers, so don't pass out the papers before. I told you that I'm going to be bouncing back and forth, so if you need clarification on something, make sure you're not waiting until the end. But the big thing is that if you do have a calculator, to avoid any confusion or anything, just bring your calculator. If you don't have one, then the same thing. I'm going to clarify that we're still fine to like raise our hand, use the computer, or use the cell phone. If you write on any scratch piece of paper, whether it's a line, just the math, whatever, your name has to go on top of it. Okay? So make sure you fill that out. If you don't pass the exam, make sure that you fill out everything. Your name, the counselor, like everything, your grade, all that stuff, okay? They want to see, we need to make it filled out. Now, for the breakdown for your exam. So for the hypertensive lecture, you have 14 questions. Diuretic lecture, only 6 questions. Heart failure is 8, angina is 6, and heme 14. Okay, that's your breakdown. And then your 2 math questions, which is why I'm talking about your calculator. May wiggle-ish a little bit, they can. I stayed up until 4 doing all of them. I don't want to look at it again, so I don't think I'm going to wiggle anything, but I might. After I get my review back, depending on how I look at it again, I keep looking at it until the day before. So this is like ballpark. It may vary 1 or 2 questions, so like not a big deal. So your heavier ones are your hypertension and your heme, because those are the ones that we have more of our time on, right? So those are bigger. Okay, come up. We ready? Y'all try to fake that you're enthusiastic about this, okay? A little smile every now and then. I see some of y'all snuggle up, sleep every now and then, okay? All right, did we finish our Praxibon? Did we talk about Praxibon? We finished it? So I think we were right here, because we talked about the Vigatran, right? Okay, so we're right here. So making sure that we are understanding that this was, it ends in MAV, right? Idarucizumab. So anytime you see anything that ends in MAV, any drug outside of us talking about these monoclonal antibodies, right? MAV says monoclonal antibodies. So make sure that you understand that. And so what this is doing is it's going to bind to the dabigatran to say, hey, remember that was our direct thrombin inhibitor. It's going to bind to that and say, hey, stop anticoagulating, like I don't need it anymore, turn it off. So it's reversing the anticoagulant effects of our dabigatran. When we look at this, make sure that you understand that this is not cheap. Okay, $3,500, and that was when I pulled it the last time. Now it's probably a little bit higher, but you see that we are looking at this for our procedures where like we need some quick off, like if we have an emergency procedure, or we like now know, hey, I'm gonna have to take this person to surgery, and I've been giving them the dabigatran. I can try to also give my Praxibon to try to reverse that anticoagulant agent that I had if I have at least that 8 hours beforehand, okay? If I give too much of something that's stopping my anticoagulant, I can have where I have a hypercoagulable state, so make sure that you're watching out for that. So you're still going to be monitoring that patient's blood level. So any of our antidotes, if we're reversing anticoagulation, make sure that you understand that you can also drive them the other way. Okay, so still monitor your patients, still looking at their vitals. And then any of our uncontrolled life-threatening bleeding, you just need some quick, like how can I help and stop what's going on because of my dabigatran? I'm looking at my Praxibon. this is essentially a summary chart to help you remember which anticoagulants we had with the monitoring, if any. And then in the middle, that's like your procedure. It doesn't say procedure there, it just says washout time frame here, but your procedure washout time frame that you have, okay? So how long would I have to have given that last dose of that medication to where I'm not expected to see an increased risk in their bleeding, right? So I'm expecting at this point that that anticoagulant effect isn't as pronounced. So this is just giving you that washout period time frame. I don't need you to remember that. I want you to know your anticoagulants and where my reversal agents are. If I specifically talk to you about a washout time, that's what I want, not for you to try to remember all the washout times from this chart with creatinine clearances and all that stuff. It's a lot. You're going to look it up, okay? Remember, we talked about our PCC with our warfarin. You also see that we can potentially consider it in our Fonda, and you also see it used in our Dabigatran, but our Praxvine is definitely what we want to use first. We talked about our Indexa that has that XA in it, so it's for our 10A meds that we're going to be talking about, okay? So look at these, look at this slide and kind of try to test yourself on where are my meds, how am I monitoring my meds, okay? How am I reversing my meds? Don't worry about the middle column. That is for your reference later if you need it. Some more check on learning questions. So mechanism of action of our rivaroxaban. A, yes, XA, right? Because remember I have my XA is in the name of these meds and it's directly most of the time in the middle, okay? So your XA are looking at your direct oral factor XA inhibition. Labs that I'm going to monitor for my patients who are using enoxaparin. Well, I heard somebody already say that. What class is this also? What is my enoxaparin? Is it a heparin? Low molecular weight heparin, right? So try to wrap your brain around some of these, because if I give you a question and when you're remembering and looking at how can I reverse stuff, make sure you make a chart that kind of looks like this on like, what am I monitoring with all of them, okay? So you could cover up this washout time frame and put monitoring right there and make a different chart to say, okay, what am I monitoring, got it, how am I reversing, got it, and have a snapshot of it. Okay, last one, 64-year-old male admitted to your facility complaining of chest pain, determined that they have an MI, they must undergo a PCI. Which of the following anticoagulants can I use as a part of their anticoagulant regimen for a PCI? Can everybody catch it? Yeah. So C, right? What was another one that we had that besides our Rivalerudin, what else did we have that was there that started with an A that we could have used? Yes. Good job. All right. I know we're not there yet. We got until Monday, okay? Well, Sunday. Don't wait until Monday. Okay? I know y'all gonna be like this. Remember also, these were also good for our patients who had a risk of HIT or a history of HIT. We could also use these medications for that also. So looking at these were the ones that we like to use, bless you, for our patients who are going to undergo a PCI. All right, fibrinolytics. So now we're getting into actually dissolving a clot. We're now busting everything up, right? We were talking about blood thinners. Now I have this big clot that I now need to bust open so that I can continue to get my perfusion back, okay? When we talk about giving these meds, if the patient is conscious, we typically will try to have them go over a consent. We also try to figure out when was their last known well, like prior to them having any symptoms, when was the last time that they were okay, because typically we're trying to give this within the first 3 hours of that last known well. When you think about this, it's like time is brain. Okay, so the quicker that you can give it to them, the more you're going to be able to help them with that, like gain that perfusion back. Okay, So within the first 3 hours, you'll see also 3 to 4.5 hours. You'll also see some providers where they'll use it up to 24 hours. And what you'll also find when you're actually practicing is some of your patients may not know when their last known well was. I could have gone to sleep and I was fine, or I could have been experiencing some symptoms, but I didn't think anything of it, so I don't remember what time it was. Okay? Sometimes you may not have the full picture, but a lot of consent goes into us making sure that we are safely treating our patients as close to that 3 hours, bless you, as we possibly can. So, when we're looking at this, this is activating that plasminogen. Remember when we talked about that, that was what was going to cleave the fibrin, which typically is what's holding or making my clot. So now I am breaking that up, okay? A clot buster. So when you see lytic, you should think of something like lysine, okay? It's exploding, I'm busting up the clot. Not what's happening with my anticoagulants, right? Or my antiplatelets. Only my fibrinolytics. So when you're looking at that, making sure that you're decreasing that thrombi, you're going to bust it up. You're going to also now think about the fact that I have now caused this thing to explode, right? I exploded that thrombus. Now it has to go somewhere, okay? So now you're worried about all of that the platelet aggregation factors that could potentially be released. So now I can have more thrombi forming. So you're trying to, when you bust up the clot, you're still going to have to use other medications to follow it so that we don't lodge those little now smaller thrombi that we like broke it up into, so we don't lodge it into like have some type of microembolism or like cutting off the circulation in our smaller arteries and vessels, okay? Remember that when we talked about our angina, we were saying that, hey, our fibrinolytics don't have any role in our in-STEMI. We were only using our anticoagulants and our antiplatelets. When we talked about our STEMI, remember I have a full, like there's an occlusion. There is a full blockage that is happening. Therefore, I'm likely to see me now using my fibrinolytic to bust that up. I needed to open back up so that I can increase that flow. So, in STEMI, you don't see this. STEMI, yes, okay? And then you see different types of PEs that are happening, and then if you have a catheter that somehow can become occluded, we can also flush some of this through a line to bust up that catheter that we have in someone's heart. So several different ways for us to look at this. Also, DVTs, we can see this used there. If they're big enough, typically and hopefully somebody wasn't asymptomatic to where that DVT got really, really large to where we had to lyse it with one of our fibrinolytics, but it is also a possibility. So again, just a cleaner summary slide of how it's working and how it's trying to get that plasminogen to go in there and degrade that fibrin. That is, at the end of the day, what we're doing with this. Looking at our two drugs that we have, and I summarized the uses, so you see like your STEMI, your stroke, your massive PE. And then looking at our the drugs that we have available, alteplase and tenecteplase. When you look at these, your tenecteplase tends to last longer, okay? Longer half-life, okay? Depends on your installation and what you have available. Some of us, we have both. Some NTS have both. And some, they just stick to one because they want for everybody to be familiar with that same dosing that they're going to use all the time, because the dosing can vary. So just depends on where you are as to what you have. Make sure that you're aware of what you have before you actually feed it, so that you can kind of know what you're doing. If that code comes into the pharmacy or into the ER, you're like code stroke, you need to know what meds you're looking for, right? You will have a pharmacist there likely, but you need to be like, hey, this is what I want, and make sure that they're also running it the right way. They're giving it and pulled it up for you the right way, okay? Our absolute versus our relative. So when we talked about our absolute contraindications, those were our absolute, like, I cannot give it to that patient, versus my relative was like, maybe I can. Under certain circumstances, I can give it to them, okay? So when you think about your absolute, think about more like head issues, cerebral issues, bleeding, recent things like a recent stroke, aortic dissection, right? Like my heart isn't pumping out things the proper way. I had a rip there in my aorta, and so I may be more cautious, right, in those patients. Versus looking at our relative contraindications. These are things that aren't as serious when I look at them, right? So internal bleeding within the last 2 to 4 weeks, that's probably resolved already. If I had if I'm gonna have a major surgery within 3 weeks, my ischemic stroke, but if it was like kind of further out there, 3 months is your cutoff for when they had a stroke. What you'll notice here though, is that age isn't a big determinant. Like, we're not worried about their age, we're worried about like how are they presenting, what is their condition looking like, okay? Can I give them this without causing an increased bleed in that patient? So my absolute is like, absolutely, I'm not doing this, versus my relative is like, okay, we got a mom, we're probably gonna do a lot more monitoring, but I'm still, or I just won't do it at all. It's still a contraindication, okay? Remember, when we're talking about our fibrinolytics, time is what? Time is our tissue, it's that brain, okay? The longer I am not perfusing, the worse off my patient is. So their last known well is very important. So when we're looking at this, who should not receive our alteplase? My 60-year-old male who has a history of an intracranial hemorrhage, my 55-year-old male who had an ischemic stroke 2 months ago, my 64-year-old patient who had a concussion after a fall 2 months ago, and then my 45-year-old patient who is currently bleeding right now. All of them, okay? None of these are good candidates for us to give alteplase. I can worsen their condition in this situation, okay? So, make sure that you're looking over this, make sure that you're remembering, I'm trying to get to them within that 3, depending on where you are, 4.5 hour time frame. Some providers will go up to 24 hours. All right, your GP2B 3A inhibitors. When we look at these and when we look at all of our different type of antiplatelets, sorry, I'll go back to this. When we look at any of our antiplatelets, so now we're in a different realm, right? So we had our anticoagulants, we had a break with just our fibrinolytics, and then now we're going to talk about all these different things that are antiplatelets, okay? When you see that G2B3A, we're not going to go into a whole bunch of detail about it because we're typically looking at one of these meds over those. So I have my prostaglandin synthesis with my aspirin. Y'all have seen aspirin, right? I'm not the first one to show you aspirin. We have some other medications that we can use to stop those platelets. We'll talk about these as well. And then your ADP P2Y12 inhibitors. So the main one that we use and that you'll prescribe is going to be clopidogrel, but we also have several others as well. Okay, so this is a good slide for you to look at the summary of kind of what your antiplatelets are and the ones that I'm likely to ask about. This I'm not likely to ask about. It is for completeness. So I'm not asking you about this right now. These are for our patients who are going to undergo a PCI. I could potentially put them on this. And then there's another medication that we're not going to talk about either. So just, you can FYI this, I'm not going to talk to y'all about it. Just know that it falls under the classification of an antiplatelet. Y'all make a big old X, you might need it one day. Y'all are like, too late. I'll look it up. P2Y12 inhibitors, okay? So now we're going into the ones that we are likely to prescribe. These are the ones that y'all are going to use more often, with clopidogrel being one of your bigger ones. So when we're looking at our mechanism of action for our clopidogrel and our prasugrel, you see that those are irreversibly binding and inhibiting that receptor, your P2Y12, okay? Irreversibly. When you're looking at your ticagrelor, it's binding the same receptor, but it's just not as tight, okay? So it's reversible. All right? You see that all of these are oral options for your patient to take, so that's also very good for us to get a response from our patient and have good compliance. So think of these medications when we're talking about our therapeutic use. Think of them as being like your ACS prophylactic medications if you're trying to prevent some type of coronary syndrome from happening, or they had a PCI procedure and now you're trying to make sure that you're preventing them from having any type of platelet aggregation, activation, all of the things. So once we do that PCI, we need to make sure that we anticoagulate them sometimes, and we'll also, for a designated amount of time. And then you'll also see where we'll do that DAPS. So remember when we were talking about that after we looked at the in-STEMI slide and our STEMI slide, and we had our little chart that talked to us about how long they were going to be on their DAPS, and this was those medications that we saw on there without all the detail. Here's now all of the detail. So to summarize this kind of as far as your uses, ACS prophylaxis and looking at like post PCI procedures is typically when we're using these, okay? Looking at our interactions, so very good medication. Think about the formulation. So I have these as prodrugs, okay? My clopidogrel and my prasugrel. Kind of lump them together. You see ticagrelor just keep getting left off to the side, right? He's reversible, he's doing his own thing, he has his own black box warning. If I have aspirin, that's over 100. So when you're studying, like, yes, they're all P2Y12 inhibitors, but kind of put your clopidogrel and your prasugrel together and your ticagrelor, like, right off those little things to the side for it that are unique to it. So if I have a prodrug and what do I need my SIPs to do? Are they activating my drug or deactivating my drug once I go through my SIP? It's activating me, right? So if I have anything that is interfering with that SIP, I can then expect to see increased efficacy of my drug or decreased efficacy of my drug. Remember that wonderful chart that we went over last semester, right? So if I had a inhibitor, what am I expecting to see with the effects of my clopidogrel if I have an inhibitor? It's going to be reduced, right? I didn't activate my drug. It's sitting in its inactive prodrug state. My concentration of the drug went up, but it's not doing anything. It's just sitting there inactive, not helping me, okay? So make sure that you're understanding just that relationship. I do not need you to remember all of these SIPs. What is the relationship? If I tell you that you had this clopidogrel or prasugrel, I'm needing you to remember that it's a prodrug. So now I need to think about sophomore semester, what happens if I have a prodrug in the presence of a SIP, and I will tell you if it's an inhibitor. And then you're going to say, this is what's happening now to my levels of my drug or the effects of my drug. Walk through it. So when you're looking at your interactions as well, looking at the increased bleed risk that can happen whenever you are giving these with an anticoagulant or any other antiplatelet. This doesn't mean that we don't do it. This means that you monitor, you watch your patient, and you make sure that they're doing okay and responding well to the treatment how you want to. That your dose is correct, and that it's not too high, and that you are thinning them out too much. Yes, ma'am.
Just to confirm, if there's a C1b inhibitor, this prodrug concentration will increase, but the actual active drug is not there, so it's nothing.
Right. So your effect of the drug is decreased. Right. Right. So look at what it, like when we talked about this, I think we had a question. Maybe, I don't know what y'all were doing with investments, but there's a question sometimes where it's like, okay, what happened to my serum level is different than what happens to the effect of my drug, right? Because your serum level of the drug is going up, but it's not doing anything when it's a prodrug and it's going up because it's not activated. Okay, so just make sure you're reading if that is something that comes up. I don't know if there's something that comes up. I was delirious last night. Your adverse effects. So looking at this, remember always when we're talking about these, that bleeding risk is something that is very serious, especially when we're talking about DAPT, okay? Especially when we've added it to an anticoagulant. You are likely to see this occur, so our monitoring is very, very, very important. Also asking the patient, hey, Did you bleed and like you bled for a very long time? Like, talk to me about that. Giving that patient history whenever they come back in while they're on these meds. Granted, typically we'll leave them on them together for a short period of time, but that's exposure for that patient, and anything can happen. So when you're looking at your bleeding risk of any of these meds, these are conditions that can now go across all of these. You see that you have your clopidogrel has the least amount of bleeding risk when you're comparing it to your other two P2Y12 inhibitors, okay? Those have a greater risk. Making sure that if you are going to do a procedure, now in every situation, we cannot have a washout period. There's some times, and you'll see it in the ER all the time, where your patients may be on some type of anticoagulant. They may be on some type of antiplatelet medication, and we have to take them into surgery, okay? We are just going to be very vigilant with what we're doing. Everybody is very observant, and we just note hey, they're taking these meds. Or we'll try to ask the patient if they're awake for us to answer that question and try to ask them so that we're ready for if they do start to bleed out, we have our meds ready, which we'll talk about some of those in a little bit. Making sure that you're not using these in your patients that are over the age of 75. Now, when we talk about this, if somebody has been taking it and they're stable on it for the most part, we're leaving them on it if they're responding well to the med. We're not usually initiating these at that point, right? Because I'm already older, my risk of bleeding has already increased. My likelihood of taking a pain med is probably, I'm tired, okay? I'm 78. I'm probably taking pain meds. Something on me is broken, okay? So when we talk about these, those are also things when they're taking NSAIDs and stuff like that, that can increase that risk as well. So we're being very, very cautious. Or aspirin, all right? Looking at your shortness of breath or your dyspnea that can occur, just make sure you're watching out for your patients who have any type of underlying respiratory disease, asthma, COPD, any of that is an issue for you, okay, in this situation. All right, our other medications that we have. There's a gazillion slides on aspirin, more than I would like to talk about aspirin. So we're going to go over, hit the high points of what we typically talk about when we're looking at aspirin and kind of focus on those, okay? So aspirin, you'll see it abbreviated as ASA. A lot of times in most people's notes, you'll see that they have ASA. Irreversibly binding our COX-1 and our COX-2, as you already know. Making sure that you're remembering that when we have that cascade that we'll see on the next slide, we're reducing that amount of TXA2, which is what is reducing the platelet aggregation, okay? Because that TXA2 was one of those things that would increase our aggregation. Remembering whenever this says that it's irreversible, once we get this, that binding or that bond, that is for the life of that platelet. So that's why we say that it's irreversible. So for up to 7 to 10 days, you're expected to see that anti-platelet effect occurring if somebody had taken that aspirin. So it's for the life of that platelet. Once that platelet dies, we're making new ones. If there is no new doses of aspirin given, I'm not going to have that anti-platelet effect on those new platelets. This is for everybody that's already been here, okay? So those are going to be the ones that are affected by our aspirin that we've taken. When you're looking at our dosing, just understand we have immediate release and we have ER. We're going to talk about these and when you're using them because there's different situations where we are wanting to use an ER versus using an IR of our aspirin. Also talking about the doses. The higher the dose, the more likely you are to see the adverse effects. One of the biggest adverse effects that we see when we're talking about our aspirin is going to be bleeds, okay, so our GI bleeds. This gets compounded when they're taking other medications that can increase bleeds. So look at the condition that we're talking about. That's most of the meds that we're going to be giving them, right? So make sure that you're, again, monitoring your patient, keeping that dose down as low as you can for it to be effective with what we're trying to achieve. So when you look at aspirin and you go and you look it up, it's going to have all of these indications and it's going to tell you all of these different doses that you can use depending on what the indication is. The big thing to also look out for is the formulation. Are they saying to use that in the IR formulation? Are they saying to use that in your XR, your extended release formulation? Okay? All right, it's telling me there's a town hall. Don't do that. Okay. This is just that same picture that we were talking about. I'm reducing my TXA, therefore I have less platelet aggregation, okay? Part of our mechanism. Looking at my immediate versus my ER capsules or my sustained release ones that I have. So remember that any of my patients who have any type of heart disease, like our ischemic heart diseases that we talked about, we said all of them had to be on aspirin, right? We were going to put them on aspirin for a certain amount of time. When we're talking about primary prevention, that's a little bit different, bless you. But if anybody that's had any type of IHD, they're going to have aspirin. We are putting them on aspirin, okay? So when we look at our immediate release, these are our ones that we are typically talking about if we're like acute, any type of acute situation. So I have a fever, I have some pain, I have a procedure that I'm trying to do right now for to get revascularization occurring. These are like my more acute, right? Because I'm immediate release. When you're looking at your ER, these are going to be for your stable situations or to prevent like stroke or something happening, okay? Because those are extended release. I don't need them to work right away. I need them to be dispersed over a longer period of time, extended release, to continue to maintain my patient. So think of your ER as more of like your maintenance situations and secondary prevention of things, okay? You see down here at the bottom the note for the primary prevention. You can see this sometimes used, or aspirin sometimes used for that, but that's up to the patient if they want to do that. So that's why you see this slide here, which is saying it's an individualized decision that they need to make. If they had some type of event, we're usually using this as secondary prevention. But as primary prevention, again, patient-provider conversation. Make sure that if they're older, we kind of don't want to initiate this because therefore we're increasing that risk of bleed that we said they're kind of already predisposed to. So just keep that in mind when we're looking at if we're going to put somebody on aspirin or not. Adverse effects, I've said it a lot of times. It's here again. Bleeding, okay? Make sure that you have and understand this washout period because this is a medication that all of our patients who have had an event is going to be on. So if all of them are going to be on this, I probably need to know, especially if it can be a scheduled procedure, that I need my washout period. Your washout period makes sense because what does this correlate to? That life of the platelet, that's 7 to 10 days. That's how long you're going to have that anticoagulant effect, right? So that's why you see that washout period being the same exact thing almost as what your the life of your platelet is. Looking at your all of these other increase the risk in using it with other anticoagulants, this is what we had already talked about. So just making sure that you're understanding that there is a risk that comes along with aspirin, even though it is over the counter, even though we're going to have all of these patients on it, we need to still monitor them, okay? Because it can become something that's harmful. And also thinking about aspirin, it comes in so many different other formulations that it could be they're getting exposed to more of this than they actually think. Okay, so we'll talk about that when we look at pain. More issues that we're talking about, and the more common issues that we're talking about are going to be those ulcers that you can see, or those GI issues that your patients are going to have. So that's the biggest thing, and then the biggest worry that we have is using aspirin in kids because they can get that raised syndrome. So we try to make sure that we are not leaving aspirin around. Also, when you think about the enteric coated, or even when you think about the chewable aspirin I think comes in like an orange flavor, and the enteric coated, it tastes like sugar on the outside of the aspirin. Okay, so think about if this were laying around. Like most meds, if you chew them or you put them in your mouth, they're disgusting. A kid may want to spit them out. These, the way that they're made, for some reason, they taste great. And so the kid might be like, ooh, this is good, right? And then we have a horrible, horrible situation. This is like, the poisoning when you have kids with aspirin is not fantastic because we don't have an antidote, so to speak, for this. We would be trying to like transfuse platelets for them. Because remember, I'm irreversible. So once I'm in there, I'm in there. So that's why we're very concerned about this. So if you do have a patient who is on aspirin, I counseling them again. Hey, make sure this is out of the reach of children, okay? We don't want our kids to get into this. More adverse effects. So, hypersensitivity. You can see this hypersensitivity occur in some of your patients, not as often. When you see this hypersensitivity occur, it's usually in our patients who have asthma. A lot of them will experience the hypersensitivity to the aspirin, okay? So that's where you're seeing that at. Your surgery is for, remember how I was telling you, like if there was a situation to where someone had too much of our aspirin, we would have to try to transfuse essentially platelets to that patient because it's irreversible. There's nothing that we can do. And then your pregnancy, depending on what condition the patient may have, because sometimes we can give it to patients who have preeclampsia, but we are typically using this later on in their gestational stage, which is usually when that preeclampsia is going to even occur. So avoid aspirin in our pregnant patients unless there's an indication as to why you're giving them the aspirin, because our drug of choice for pregnant patients is always just going to be Tylenol. Their head could be falling off, Tylenol, okay? I'm being very dramatic, but remember, Tylenol is our drug of choice for our pregnant women. We are not giving them aspirin unless there is a specific indication as to why you're giving them aspirin. Okay, your dipyridamole. When we're looking at this, several different formulations that we have, our PO and our IV. What this is going to do is decrease that platelet aggregation by inhibiting your adenosine reuptake and by stimulating CAMP. Remember when we look at CAMP, we're talking about prostacyclin. So if I have more of that prostacyclin around, now that's where you're seeing the effects of this medication occur, and then you're stopping the aggregation from happening, okay? We're breaking up the party. Us using this alone is not something that is very effective. Typically, when you're using it by itself, it would be for a perfusion test. If you're trying to see like how somebody is going to perform and they can't exercise, we can use this medication to see how their heart responds to it. But when we're using this as dual therapy, you'll see that we'll have it in conjunction with aspirin for ischemia, or you can see it in conjunction with warfarin for our patients who have a thromboembolism, if they had a valve replaced, like a heart valve replaced, okay? IV, I already told you about when we would be using that IV formulation. That's if they don't want to exercise. So in lieu of exercising, I can give them this to do my imaging, perfusion imaging. Adverse effects. Think about our CAMP that we were talking about and all those things, right? So now I can have flushing. Now I have dizziness. Because I've opened everything up so much, my head's hurting, right? Because everything is just flowing a lot quicker. And then you see this coronary still that can happen in some of our patients. So if somebody has any type of ischemia that you're already knowing that they have, avoid giving this medication because it can potentially make it worse for them. Our antidote, we don't have one. The washout for this, I don't need you to really focus on that, but it's not as long, right? 2 to 3 days versus how we were looking at our aspirin. But we already said that typically when we're using this in conjunction with aspirin, so kind of negates the washout period of this. Your drug interactions, just make sure that you're watching out with your anticoagulants, which there will be some situations where you will see these medications used with our anticoagulants, okay? Just make sure that you're looking out for that bleed that they could potentially have. And then your adenosine levels would be increased. So when I increase my adenosine level, make sure that you're understanding I'm going to have more vasodilation. Therefore, when I have that vasodilation, I can potentially drop my heart rate. And then our acetylcholinesterase effect, okay, of our cholinesterase inhibitors, making sure that you're understanding, especially in your patients who have MG, that you can worsen their condition. So this goes back to one of those our sophomore semester things that we were talking about, okay? So just understand that you have those different inhibitors that you can have, donepezil being one of them, your rivastigmine, and understand that those they can lead to increased muscle relaxation, essentially, right? So that's why you see the aggravation in your myasthenia gravis patients. This is our combo, which is called Agrinox, and how we are going to typically prescribe this medication. So now we essentially took those two medications that we talked about, our aspirin and our dipyridamole, and we added them together. Do not feel like this is not one of the ones, you know how I tell you sometimes like, oh, it's two drugs and you can just order those two drugs separately. These are not interchangeable with taking them separately. Like the way that they formulated this, it doesn't make these two things just interchangeable. So if I told you that somebody has Agrinox, that does not mean that you can just go, okay, here's some aspirin and some dipyridamole and you should be okay. Okay, so they're not interchangeable. Looking at the mechanism, it's the same as we talked about them separately, but now you have them both working together. Our clinical use, we already said that we were going to use this for our secondary prevention for our patients who have had decreasing the risk of them having some kind of stroke. Oh no. Was it open? Oh. Okay. When you're looking at your considerations, we already talked about this. Make sure that you're understanding that in this, when you give this and when we dispense this medication, we tell them to keep it in the original container. Make sure that you also let your patient know, keep it in the original container. We're trying to protect it from moisture, so much so that the way that the manufacturers made this pill bottle is that like the lid has like a decusant, or I think that's how you say it, desiccant in it, to where it's trying to suck the moisture out of, like any moisture that gets into that bottle out of it, okay? So make sure that we're watching out for that. Our interactions, again, bleed risk, making sure that we're not using it in our children. The way that we're looking at children here is trying to say, and for you to remember, don't use it in anybody who's under the age of 18 for us talking about it purposes. Also, another one that's not on here, sometimes our patients who are recovering from like chickenpox and different viruses like that, the flu, they can sometimes associate those with Graves' disease, and so that's why we'll also try to avoid aspirin in those patients who are just now recovering from that condition, or they actively are having the flu or chickenpox outbreak. Okay, Celestazole. So this one is an oral medication that we have that's available to us. Essentially, your mechanism here is decreasing CAMP, therefore you're going to have vasodilation, and with that vasodilation, you have the decrease in your platelet aggregation. So very similar to what we've already been talking about when we were looking at our dipyridamole. This is better when you're than using just aspirin alone, so we like to use these medications to try to remember to inhibit that platelet aggregation. My clinical use that I have, so when you're looking at clinical use and we're talking about this intermittent claudication or your muscle pain, this is pain that is happening because they don't have enough blood flowing to whatever that muscle is. And so they have that muscle pain. It could be while they're exercising, it could be while they're just living, their daily life. So if you have somebody who comes in with intermittent claudication or that muscle pain, you can give them this medication. The way that you're monitoring the effectiveness is, hey, can they now do more things without having those pains that they were feeling, right? Because if they can, that means that I was able to vasodilate enough to increase that blood flow to that area. I'm expecting to see them now be able to be more active, okay? And then looking at this where it says probably, right? Probably beneficial for somebody who I had to go in and put a stent in, okay? If they had some type of PCI type of procedure, or I did any type of angioplasty, I'm worried about keeping them open. This could be one of those medications that could help with that. And then I told you it's better to use this with aspirin so you get a better enhanced response than just using it by itself. So that it's kind of like you're double blocking again, so adapt with that, with adding aspirin to it. Our adverse effects, several of them listed here. You see that I have the different percentages. You're more likely to see the headache because we had that vasodilation because of our CAMP, right? We're looking at our big issues that we're worried about that could become more serious. Is going to be those cardiovascular side effects that you see at the very top. Not saying that they're more prominent, but those are the ones that could be more deadly to our patient, especially if they have some type of underlying heart condition or they're already tachycardic. Looking at my black box warning, make sure that if your patient has heart failure that you are avoiding it because you can increase their mortality due to that risk of the arrhythmias that we talked about in the side effects, okay? So we're gonna avoid it there. And then our drug interactions, more SIPs, so just understand this, drug interaction, and I don't have an antidote for it, so just understand that. I don't need you to remember the washout period days. Okay, this is looking at PEs or our pulmonary embolisms and trying to figure out what the severity of them will be. I am going to tell you the severity. So this is more so like for your information to kind of look at it and say like, oh, okay, this is what the definition of that is. You're going to see this. Some of this you probably already saw last semester. So when you're talking about your massive PE, you have some type of hypotension that's coming along with it, bradycardia. There's some type of hemodynamic instability that is occurring in that patient. When you're looking at your submassive PE, you don't have the hypotension, but there's some type of issue with our cardiovascular system and us not having that demand met how we should. And then your low risk PE is that they're not going to have any of those clinical markers that we talked about in our massive or our submassive, is how I remember it, okay? This is a summary of the recommendations of if you're going to use a fibrinolytic in your patients who have a PE. So when we're talking about this, if it is massive, and always when I think about like a fibrinolytic, I think about something being like very big to where it is obstructing something. And my only option that I have will be to bust it up or just like make it disseminate, right? So when you think about your fibrinolytics, try to remember them that way. You're also going to try to remember the fact that anytime you give that a fibrinolytic, you're risking further complications, right? So make sure that your patient is aware of the risk versus the benefits with that. You see that we also can use it when we're talking about our submassive. You see that it's not recommended if they have a low risk PE, so the one that was at the very bottom, they were hemodynamically okay. Or if they have that minor RV dysfunction, if they have the submassive. And then not recommended if we don't know why they're in cardiac arrest. If something happened, we need to fully work up our patient because we could make their situation a lot worse if we try to life them, okay? This is just a picture giving you all of our different types that we had and like kind of putting this into words. Understanding that we're going to anticoagulate any of these patients as soon as we figure out there's some type of PE. Okay, cool, let me anticoagulate you. So you see that I have my heparin and I have my low molecular weight heparin. Then you start to work your way down. Because I'm low risk, there's no reason for me to have my fibrinolytic, right? This is what we were just talking about. Whereas when I'm looking at my submassive and my massive, depending on what's going on, I may or may not need to have that fibrinolytic. So if I have that RV dysfunction, I'm not a candidate, right? So I'm going to go towards that no. Everything else, bless you, is kind of shifted to us looking at our right-hand side where we are going to give a fibrinolytic if there is no contraindication to us giving that fibrinolytic, okay? Make sure that you are understanding if you need to give it or not. And when there's a contraindication, what do my contraindications look like? When we look at this, once our patient is hemodynamically stable, we're typically going to try to put them on a DOAC, okay? Our DOACs are the easiest thing for us, it's the easiest thing for our patient, right? I don't have any monitoring that I really need to do, and it's easy for my patient because it's just a pill that they have to take. They're not injecting themselves, we're not worrying about any of that. So we really like to use our DOACs in those patients, okay? Kind of help us with decreasing their mortality risk and also like them having this occur again, okay? When we come back, we'll start here. 10 minutes. Exams and stuff for me. All right, so when we're looking at our agents to treat bleeding, right? I have overdone it. And now I'm trying to figure out how I can clot my patient, right? So I've been talking about us trying to get rid of clutch, trying to get rid of our thromboembolisms, all of those things, our patients who are having DVT. So this is essentially me trying to say, I need you to now reverse it. I need you to clot. Okay, so this is our clinical uses that we're talking about. We can also have some of those diseases where, again, like our deficiency, our natural anticoagulants aren't there anymore, and so I'm thicker. My blood is, or protein CNS. So yeah, and then our agents that we have. So depending on what's going on with your patient, and hopefully you don't have to do this, blood transfusions are definitely an option. When we're looking at our drugs that we have available, you see your cryoprecipitate, your PCC that we talked about already. We have different forms depending on where you are. You may carry one or the other. Some places they do carry both. Typically I see Kcentra. And then you also have your profiline. Make sure that and I don't need you to know this for the test, but like in real life, you see that they have different factors. So depending on where your patient is deficient at, you'll see that different factors are being replaced. They're not exactly the same. So don't think that these two things are necessarily interchangeable. Okay? Net result is that we're going to eventually get some clotting because we're replacing clotting factors, but just understand that they're not the exact same things that you're getting in both of these formulations. And then your TXA or your tranexamic acid is another one that you can see used. This one is very common for several different things that we could have. And then your adverse effects, I did too much, right? So now I caused them to be hypercoagulable, so you can have more of those thromboembolic events occur because now I'm doing the opposite of what I've been trying to do this entire lecture that we've been talking, okay? When we're looking at our TXA, two different ways that I can take it. I can do my oral formulation, I have an IV formulation. Looking at your mechanism of action, remember that our plasminogen to plasmin, that was what was hydrolyzing or cleaving that fibrin, okay? So that was what was lysing that fibrin. So now I'm trying to reverse that from happening. And then my clinical uses that I have, if I have patients who, when they have their menstrual cycle, they're bleeding very heavily, or if they're becoming anemic every time they have their cycle and you can relate it to their cycle, I can use that oral formulation. If I have a person who has an underlying bleeding condition and I have to do a procedure on them that's going to be scheduled, I can also give this medication. So any type of condition essentially that you think that would increase their bleeding risk. They were thinking about doing surgery on my daughter for her tonsils. And because she has OI, they have issues with their collagen and their clotting factors. So they were worried, like, hey, if we do a surgery, there's a potential that she can bleed. So we were talking about using TXA prior to the procedure, okay? So if you have any type of condition where you're suspecting that there could be an increased bleed risk, this is always something that you can throw on board before they actually have that procedure, or have it on hand, give them that IV if something if stuff hits the fan, okay? Adverse effects, we already kind of talked about them, but a big one that you can see here is going to be headaches, and they're going to have like some pain in their abdomen area. Most of the time though, we're looking at headaches, okay? PK parameter, looking at renal, so if anybody has any type of renal damage, renal issues, we need to make sure that we're looking to see if we need to dose adjust if their creatinine clearance is within a range that we can do a dosage adjustment. Precautions if anybody has any of these conditions that we just talked about. Looking at our ACS, we already saw this same exact chart. Okay, so looking at our DAP and when we're going to be using that depends on the condition, depends on how bad your patient was. I have up to 12 months. Sometimes we'll see like 6 to 12 months of where we would leave our patient on both of those antiplatelets, and then we typically take them off of both of them and they will stay on one. Most of the time we'll keep them on aspirin. And then you see all of our other medications that we were using as our secondary prevention once somebody had that acute coronary syndrome. So if they had anything that occurred, this was like their take-home packet that we were giving them. Okay, these are all the drugs that we were giving them upon discharge. All right, we talked a lot about bleeding, so now we're going to look at anemia. And when you think about anemia, I want you, and we're looking at the treatment of them, I want us to think about, we have oral options and we have our injectable options that are available to our patients. From this slide, I don't need y'all to remember anything, okay? This is for your situational awareness, for you to kind of get the background of what's going on when we're talking about anemia and the fact that we don't have our oxygen essentially carrying, or our blood cells carrying enough oxygen to our body. Your patients are going to be very tired. A big thing and a big way that you can help is, especially in your patients who have heavy menstrual cycles, is to look out for this. When you get those labs back, if you see any type of anemia, you're trying to snoop around and figure out what is the underlying cause. Are they bleeding from somewhere internally? Are they bleeding heavily whenever they use the restroom? That happens also in a lot of patients, to where they'll go to the restroom, and when they go number 2, they will have a lot of blood that's coming out. And they don't say anything, they don't think about it, and that's sometimes a big cause as to why you have some patients who have unexplained blood loss. Go do a colonoscopy, figure out what's going on. So we have different types. Iron deficiency, which is most common, our B12 deficiency, and our folic acid deficiency. So depending on what type they have, we're going to treat them. I, again, will tell you what type they have. You will say, this is the medicine that you're going to use. So that's why I'm going through these kind of fast, because I don't care that you know all this. You're going to learn all this somewhere else. This is for completeness, because I know some of y'all are like, but why? Those are your but whys. So when we're looking at our iron, again, if I give you a lab value, I will tell you also on the exam if it's low or if it's high. I'm going to tell you that. I did decide for your exam that I'm not making you remember if something is stage 1 or stage 2. I should have, but I didn't. So if something is stage 1, it's going to say, oh, their blood pressure is high, stage 1, okay? And if it's real high, it's going to say that it's high, and it'll tell you that it's stage 2, and you just need to tell me what you're doing, okay? What meds you're using. Okay? Y'all are like working. I'm working. So when we're looking at this, okay, just understand I'm trying to replenish these things, right? I'm trying to make these things better. More background information for you. I'm just trying to get us to our drugs, which is right here. This is what's important for us, and when you look at your different iron supplements that you have, you're worried about the elemental iron. How much elemental iron is actually in here? How much am I going to be potentially getting to my patients? So you see you have your ferrous gluconate, which has 12%, your ferrous sulfate. This is the one that we typically are going to prescribe. And then you have your ferrous fumarate. It has more elemental iron, but we don't, we are typically going with sulfate. It's easier on the stomach, because a lot of patients are going to complain to you about how they have constipation and their stomach hurts whenever they take their iron. So, looking at your dose, I don't need you to remember the dose, just know that they're taking it every single day, and that most of it that they take is not going to get absorbed. So, 1/4 of what they take is what we're actually going to have our patient absorb. Depending on how anemic they are, you can either choose to give them oral formulation, or they will have to come in and get infusions. Remember that you're always trying to figure out what the underlying cause is, if you can find it, okay? Continue to treat that patient. You're going to treat them for at least 3 to 6 months before you bring them in and say, like, okay, hey, what's the underlying issue here? Did I replenish you? You try to take them off of it. If they become anemic again, you know that there's something more chronic going on. You know that there's some type of underlying issue that you have with this patient, okay? And some people, they are anemic, and they will be on these meds for a very long time. Precautions. So, if I want to try to increase my absorption, make sure I get as close to that 25% as I can, I'm going to tell them to take it with food. The other benefit of them taking it with food is that they can have a decreased GI upset that a lot of people will complain about with this. A big thing that freaks people out is that they become constipated, and then when they finally do go to the restroom, it's black. That is from the iron. Let them know that they aren't blue, like if it's not bright red, that's typically being caused by the iron that they're taking that has discolored the stool and made it black. So counsel them about that. And then for the constipation, just make sure that they're increasing their fiber intake. They're drinking water, right? The basic things that we typically will tell somebody to do, but now it actually matters because they have a med that is very likely to cause constipation. It is very likely to cause those black stools. Those are two of the biggest things that you're going to hear people complain about. So those are the two side effects that I put on him. Looking at our IV use. So when we're looking at our IV use, we are typically doing this because our patient cannot tolerate oral for whatever reason, they're not responding to it. Then that's when we go to IV. So we always try to start with our oral if we can. Safe in pregnancy after that first trimester. So again, just make sure you're reserving it for later. And then you have all of these different options that you have here. So you have your dextran, your sodium ferric gluconate complex, iron sucrose, your ferroxymaltose, and then your ferric carboxymaltose. We typically will see that ferraheme being used. So just make sure that, again, check with your patient, make sure that they're taking it how they're supposed to be taking it before we just say, all right, I'm going to put you on IV. Adverse effects, we talked about these, right? Some GI issues are going to be your biggest complaint. Because I can take it with food to help increase the absorption, I'm also helping minimize that GI issue that I have as far as the cramps. Constipation, I'm combating that with fiber, and I'm drinking more water as well, okay? And then my hypersensitivity reaction. When you see this hypersensitivity reaction, this is more so talking about your patients who are going to get the IV formulation of your iron. It can be very serious. Typically, you're going to see this when you're running things a little bit quicker. So make sure that you're running it at the rate that it tells you to. Again, look it up on Lexidrug because it's going to be right there. And sometimes what we do is we'll try to give them a little test dose to see how they respond to it before we actually run that full dose of the medication for them. Our fatal overdose you see with some of our patients is possible. So we have our deferoxamine or our Desferil that will bind to or chelate with that iron and treat the toxicity that we could be seeing in our patients. This is if they have anemia due to a vitamin B12 deficiency, okay? So if they have that as the issue, this is just again showing you our mechanism and how it's working, but I'm going to tell it to you here. If they have that issue, what do you think I'm going to give them? B12, okay? So if that is their issue, I'm just going to say, hey, let me give you that vitamin. What they're doing with this though, this is not an oral, but they can take it at home. It's going to be an IM injection that they're giving themselves. If you order this, please order a syringe for your patient because they can't just drink it, they have to inject it. And if you don't give us a prescription for that syringe, we don't usually give them out in the pharmacy. We need the prescription for it, okay? So initially they'll take it every week for the first month, and then after that they can kind of start spreading out their injections to every 2 to 3 months depending on how they respond, but that's because they're able to now have those stores built back up again. So all I want you to know, I will tell you what it is. So all of this other stuff with they don't have the factors present, the intrinsic factors and the distant, I will tell you what kind of anemia they have. I'm not expecting for you to diagnose it, I just want you to know what you're doing, okay? So our two forms that we have, the hydroxycobalamin, which is the one that we typically give, and then your cycanocobalin that we have. Oral B12, that's if it's not as bad or they can't tolerate our IM, but most of the time they're going to inject themselves when we're talking about our B12. Adverse effects, shock, potential death, haven't seen this. Most people tolerate it very, very well. This is if I were going to be giving it IV, not looking at my IM formulation. Cardiovascular issues, okay, so making sure that you understand that this could increase that edema and therefore worsen patients who have heart failure, especially earlier on when they're not as used to this medication as they will be later on when they continue to use it. Derm-wise, itching, especially if they have hypersensitivity to it. Again, not something that I have typically seen, and then swelling because of the edema that we already talked about. Folate, which is vitamin B9. When we're looking at this, essentially what I'm wanting you to know is if it is because of a folate deficiency that we are going to, okay, computer, come on. If it's a folate deficiency, we're going to give them folic acid, okay? I'm replenishing what they don't have. So my B12 and my folate deficiency, I'm just going to give them B12, I'm just going to give them folate. When I look at my folate, this is a tablet that they're going to take, and they're going to use this tablet and have it once a day, okay? When we talk about folic acid, it needs reductase, and leucovorin doesn't need that reductase, okay? So just understand that you have those two different options that you can give that patient. So if there's an issue with the reductase, then we're going to end up giving them the leucovorin. Why are you freezing here? It doesn't finish in 2 minutes. Okay. Now, this is looking at different growth factors that could be causing me to be anemic. If there is an issue, I'm going to tell you what the issue is. Essentially what this is talking about is if I bind my red blood cells and I prevent apoptosis, which is what the drug is trying to do, then I'm going to help that maturation. I'm going to help have more of those red blood cells around to where I'm not as anemic, okay? That is your mechanism of action when we're looking at our erythropoietin. So, here are different types that we have. You have your epopoietin alpha and your dabropoietin alpha. Both of them, as you see, are IV formulations. We just talked about what our medication was and what our mechanism was. Our clinical effects, these are for your patients who are going to be very, 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 very anemic, and then also looking at them, they have renal failure, they may be your cancer patients, like these are patients who are going to be on your more severe end of the spectrum. I could be preparing for a surgery where I could potentially lose a lot of blood. These are all things where I'm trying to get them ready, I'm prepping them for what they are about to go through. That adverse drug reaction of an increased risk of those serious cardiovascular events used to be a black box warning. It is no longer a black box warning. They took it away. So just understand that this is a medication that can be very harmful to your patients, especially if they have any underlying cardiovascular disease. See hypertension, all of those things that are occurring there because of us having that in the seizures because of that rapid expansion, right? Because I'm now letting those red blood cells mature before they're dying off. So now they're getting bigger. Now I have a higher capacity. So therefore I'm starting to see that I have hypertension because my blood volume is now expanding. So monitor your blood pressure in these patients. Make sure that they're okay. Your hemoglobin, like I told you about. Looking at some cautions that we have, making sure that if their hemoglobin is over 10 grams per deciliter, you're not going to start this medication. That is a big thing that I wanted to say because when we're starting it, if they're not as crucial, we have other options that we can give our patients, right? And you see that this doesn't come without side effects. This comes with serious side effects. It can harm their heart. So therefore, I'm trying to make sure that I'm doing my due diligence with making sure who gets this medication. And it's kind of serious and invasive, right? It's a transfusion that they're having to sit there for, and if I don't have to do this, then I don't want to. You see the different response days. I don't need you to remember any of that. When you're looking at the comments of comparing your epopoietin to your dabropoietin, I do want you to look at that. Because you see when I'm looking at my epopoietin, I'm not really seeing a huge benefit whenever I'm using it for my acute anemia, but if I'm comparing it, and also the frequency of the dosing is more often than if I'm looking at my dabropoietin. And you also see that ties into the fact that it has a longer half-life, right? My half-life is longer, therefore I don't have to dose it as often. And then this FDA warning, just make sure that you understand that it's still a warning. It's no longer a black box warning that we had to worry about. Okay, so all I want you to know with that warning or that issue is that because of those cardiovascular events that were occurring, this was something that we were very concerned about, them having those increased events happening, and then the increase of those events were more likely in our patients who had cancer. Two more, and our last two that we're going to talk about are our filgrastim and our cerebrastim, or our leukine. When we're looking at these, just understand that these are like our man-made medications where we're trying to mimic the substance that our body normally has, and it's trying to help us make more blood cells. Okay, when you're looking at your sargrammastim, again, another one that's man-made, and is again trying to increase or stimulate those blood cells as well. So looking at your effects that you have, or whenever you're using these, you see that these are again more of our ill patients, our sick patients who are kind of immunosuppressed. And so we're trying to help them be able to have that increased response and those increased red blood cells to meet their oxygen demand that they have. So patients who are undergoing any type of chemotherapy. So when I think about these, I think about my super sick patients who are either undergoing chemo or they have some serious type of transplant. Adverse reactions are going to be my anaphylaxis potentially with these medications, and then you see your box warnings that can happen. So nephrotoxicity, hemorrhaging that can occur, your ARDS or your respiratory distress syndrome where they're going to have issues breathing. That's looking at your filgrastim. Whenever you're looking at your sargrammastim, that first dose effect, you're likely to see that respiratory distress with that first dose, but after that it should be going away. You have the edema again, and then all pulmonary symptoms. So whenever you see edema, just be like, oh, they have so much fluid on them, it's hard for them to breathe, right? Try to associate those two things together. And then with our comments, whenever you're looking at this, just understand that there are different cutoffs. I'm not going to specifically ask you about these cutoffs, so you can read those, but just these meds seem very low threat, but as you see, these are very serious medications, and I know they're like the little last caveat. Hopefully they're not something that you have to use very often in your patients, but this is more so like when we're talking about you're chronically like, I can't, outside of my normal iron pills that I'm giving somebody, this is more of your serious patients where you need to replenish their iron stores, their B12 stores, their folate, okay? And again, if you have a question on this, I will tell you what they have. You're just going to tell me what drug to use. Okay? Look at your mechanisms. Look at your big warnings for all of these that we talked about in your adverse drug reactions. Okay? All right. Again, if y'all have questions, you can cancel for tomorrow because we don't need tomorrow. Just tell them that we moved up. Okay? Tell them that we canceled it and be like, oh, yeah, I didn't need class. Okay, and then I'll find something else for you to do. Just kidding. If you need me, please, again, make sure you try to find the answer. When you're asking me the question, like, be specific, like, what is it that you're needing for me to do? What is it that you're not understanding? Do not email me. Do not write me on Canvas because I'm not going to just have my computer with me. I'm going to be on leave. I'm going to have my cell phone. So if you have a question, you need to text me. Okay, because if you don't, I probably won't see you. All right? Make sure you rest on Sunday. I know y'all are like stressing. I'm not trying to kill y'all. I know y'all think I'm trying to kill you every semester. But I promise you I'm not. I gave you all of those reviews. The last caveat about these reviews, they are great reviews. Okay? Use them how you need to use them. All right.